या कुन्देन्दुतुषारहार धवला या शुभ्रवस्त्रामृता या वीणाभरदण्डमण्डितकरा या श्वेतपद्मासना या ब्रह्माच्युतं शङ्करं प्रभृतिभिः देवैः सदा वन्दिता सा मां पातु सरस्वती भगवती निःशेषजाड्यापहा।
Good evening, everyone. It gives me immense pleasure to welcome all of you today in this program of O2S webinar web series. This is our 9th episode that we are having today. And first of all, I would like to wish all of you a very happy new year. And it gives me again a lot of pleasure in welcoming you to this on this Foxy Foundation Day that we are having today. So welcome all of you. This program O2S webinar, which covers like from the A to Z of obstetrics, is convened by Dr. Jaideep Tank sir, co-convened by Dr. Parikshit Tank, and Dr. Jaideep Tank sir is the one who has thought about it, planned the whole thing, and it amazes me when I think about it that just before when we had the briefing meeting, he had the planning for the whole 23 webinars on paper and pen, and he just passed it on to us, and we had to do the calling and we had to plan it and just set things right. So thank you so much, sir, for planning such a wonderful webinar, which is benefiting, I'm very sure, all Foxians who are attending this session. I have a wonderful set of moderators also along with me, Dr. Apurva, Dr. Niharika, and Dr. Rohan, and four of us, sir has given the responsibility to moderate this program, and hopefully we are doing a good job. Thank you, sir, for the opportunity as well. So today's webinar, we have two wonderful talks, one on vaccination in pregnancy and one on nutrition and lactation, and a wonderful panel discussion on multifetal pregnancy. To start off with the session, I would first of all like to welcome the chief guests of the day. First one, Dr. C.N. Purandare sir, Professor C.N. Purandare. Everyone knows sir. He's a past president of FIGO, past president of Foxy, past secretary general of Foxy, and he has been awarded the fellowship honoris causa by RCOG. Sir is like a fatherly figure for all of us, and whenever he meets us, be it very junior or senior, his smile definitely like gives a lot of energy and a lot of like the love and care that he gives to us. So welcome you, sir, to this platform and request a few words from you, sir.
Good evening to you. Want to introduce Nozar as well first, or yeah? Good evening to all of you, and happy New Year to all of you. And I must say that it's a privilege today to be here talking on this O leading to S, which I was a bit confused because these short forms. The only ones which we learned during our time was NAD and NBM, and that's all we knew about. And this O to S was something new to me, and was interesting to know that it's A to Z of obstetrics. When you're looking at the obstetrics per se, you find that most of the country people are shying away from taking up obstetrics because of medical legal issues and a lot of other problems that are happening in the training process. And today people are grumbling that the cesarean section is rising and normal deliveries are not happening the way they were happening before. And when you look at it realistically, I think over the years, the situation has also changed. in obstetric practice. We are having high risk patients. We are getting patients who are over 40 consistently, which makes it difficult to maintain a cesarean section rate of 15% the way WHO suggested, and it went on. And the best of institutions today, when you're talking about the National Maternity Hospital, which started the active management of labor and said that their cesarean section rate that time was around 7%. And today they are also at 22%. So this is not something which is happening in this country. It is happening all over. And obstetricians need to work with the lawyers looking over their shoulders for everything. And I mean, it's all aspects of obstetrics. The lawyers are looking over your shoulders, whether it is normal delivery, you'll be sued. You do cesarean section, you'll be sued. You do anything and you can be sued. And there are lawyers who walk down the corridors of hospitals in asking for patients whether they would like to sue the doctor and make a deal 50-50 or whatever money that is coming between the legal expenses and profits for the lawyers as against the patient that is getting it. So there are so many things which are happening, and I'm happy to see that all these 23 series work will highlight all the aspects of obstetrics that we face right throughout. And I recently read an article written by one of my juniors on obstetrics and their life, the way they have one of the GMC ex registrars. And I mentioned that this particular statement I made in FIGO's meeting, that we need to revive the art of obstetrics. Unless we revive the art of obstetrics, we will have only two types of deliveries: one a cesarean section, and the other accidental vaginal delivery, because there is no doctor around. So this is the situation that is happening. And there are so many other aspects of continuously newer things that are coming up. And I'm happy to see Jaideep discussing about vaccines, because we have now the COVID vaccine which has come in, and the ACOG recommendations, FIGO recommendations, as well as all the other countries are putting up their recommendations on what should be done as regards vaccination. And Anita, who's going to moderate a session on multiple pregnancies, which is also a very important aspect, considering that some of the IVF specialists have gone overboard, putting in 2 and 3 and 4 embryos inside, resulting in multifetal pregnancies. So this is something which needs to be discussed as well. And I'm happy that Anita, when she came here to India, was one of the very few people who was dealing with this kind of thing, fetal medicine, with the twin-to-twin transfusion and so on. And I've always had some very good words about her from my dear friend in UK, Kipros, whom I always meet for dinner whenever I'm in London. That needless to say, we all know that she is doing a wonderful job here in India. So it is good to see everybody here. I see Noza there. I have not seen him in person for a long time now. It's all last 9 months on screens that we are seeing, all of us, each other. And I hope with the vaccine now coming up in India from 13th of January, hopefully maybe sometime in February and March, Jaideep can organize something in the Foxy office where we can at least have a cup of tea together, having all vaccinated. So anyway, congratulations to Jaideep and Parikshit for organizing this, and all the very best to you for all the episodes that are going to take it further. Good luck.
Thank you very much, sir. And I cannot help but say these couple of things about sir. Everybody knows about sir. Everybody knows about his legendary academic career and professional career and all. But I don't think many people are aware of this very keen sense that he possesses of what makes organizations work. And I have seen Sir since I have entered Foxy in relatively late in around 2000 and 1999 and so on. And the sense of purpose and the sense of what makes an organization and its people tick, I really don't think anybody in the world can compare to CN Sir when it comes to this. Uh, the other special, very, very special thing about Sir is I think his ability to pick up talent and nurture that talent and inspire such a fierce sense of loyalty. I mean, if you go to a conference, it sometimes becomes difficult to walk with Sir because everywhere, every after 5, 6 steps, somebody is coming and touching Sir's feet. And I think this is something which is really very, very inspirational. And it's something which one can really learn from, this sense of loyalty, this sense of bonding which Sir has managed to achieve in so many years. And what's most important is sustain it. I think sometimes, when somebody is working with you, it remains, but Sir is one of those rare individuals where that bond remains, sustains, and over a period of time actually grows very strong. So thank you very much, Sir. I mean, I just thought I'll say, these are things which people don't always talk about you, but they have always struck me as some of your most remarkable characteristics. So thank you very much, sir. I know you are very, very busy, and I'm really grateful that you took time off to come here.
Pradeep,
Of
I
course,
just want to make one comment here that I have always
yes, sir.
considered your father as my teacher's teacher, because Dr. Belvi was my teacher under whom I learned a lot of things. And I think my success going to Ireland um, is majorly because of him, what he taught me as obstetrician and gynecology. And I still remember, Jaideep, which I don't, any of the panelists or anybody would ever have seen it happen, that when I was an intern and I was at Rajawadi Hospital, and Jaideep's father was the unit head, one day he walked into the theater and he asked me, what do you plan to do after your internship is over? So I said, I want to do obstetrics and gynecology. He said, the next hysterectomy is happening. I want you to do it. I couldn't believe it, that as an intern, I was going to sit and do a hysterectomy. And believe me, he told the registrar, who was absolutely one of the finest registrars I've ever seen, Mulgaonkar, who just stood beside me and he said, go on, I'm here, not to worry. And I just can't imagine anybody ever doing a vaginal hysterectomy during their internship. I think that's something, legacy which has come through, and I think that has to go forward in your juniors that you train. And I can see Datta Panandikar there, who was my registrar as well, who's now become webinar king, as I should call him, because he seems to be doing webinars every other day. And that's the whole. We have a group of nearly 100 of my residents who are on a group which is constantly on, and I am amazed at their contribution each one of them have done in life going ahead. So thank you very much, JG.
Thank you. Thank you, sir. Thank you. Thank you again, sir, for making it for this webinar. Priyankar, please go ahead.
Thank you, sir. I completely ricochet sir's thoughts and his words. Thank you, sir, Purandare sir, for being here with us, because we all know that you're very busy, and thank you for being here today evening. It means a lot for us, sir. Thank you, sir. So I would now like to introduce Dr. Noza Shariar. Again, everyone knows him. He was the past chairperson of the MTP committee, Foxy. He has worked as a Secretary General of Foxy and also as the president of the Mumbai Obstetrics and Gynecological Society. He held the coveted chair of the scientific chairman of the FIGO conference, which was held in Rio in 2018. He is also he's also in the governing board of the IPAS, and moreover, he has won a number of awards And to name a few, the AFOG Young Gynecologist Award in 1993, a number of awards from MOGS, Foxy. So I welcome you, sir, to today's evening's program, and thank you for being here. And I request a few words of forward-looking words from you, sir. Over to you, Nozar.
Thank you so much, Priyankur. It's a pleasure for me to be a co-chief guest with Ranjan, my very closest friend, and obviously the person we all look up to, like Jaideep said. And the only reason I said yes, Jaideep, because it's a program that's organized by you and Parikshit. Otherwise, being chief guest is not something that I greatly want to be part of. Anyway, O2S obstetrics is what all of us are passionate about. I am passionate about obstetrics. I love obstetrics. And I remember writing a piece in one of our MOGS bulletins, and it was in fact picked up by the FIGO newsletter a few years ago, where I just said that as an obstetrician, we have the best job in the world. We have it all. Okay, we've got surgery, and it's the thrills of surgery. We've got the adrenaline of obstetrics. We've got endocrinology. We've got obstetric medicine. We've got the latest technological advances. And most importantly, we are there to champion the cause of women. We can be their advocates. We can be their voice. And I go to the extent of saying we even have to be their co-conspirators. So thank you for doing a masterclass on obstetrics. We do so many meetings today on more advanced subjects, but I think this probably is what we are rooted in or grounded in. I'm looking forward to Jaideep's talk. It's going to be interesting because Jaideep does any talk well, and immunization is so important for us in clinical practice. Krishnendu, of course, another dear friend. Nutrition, if I would suggest the two so-called not very glamorous parts of our practice, but probably the most important parts of our practice are immunization and nutrition. And Anita, CNS said about how accomplished she has been, and I look forward to that panel discussion as well. Now, the importance of the masterclass is brought out by something Anton Chekhov said. Chekhov said that knowledge is of no value unless you put it in practice. And that's what we do. In medicine, we practice. In fact, I sometimes, in a lighter vein, believe, patients haven't really caught on. Patients come to us where we practice medicine. And I'm sure one day a patient is going to ask me, Doc, don't you think at some point in time you need to perfect it? Are you always going to keep on practicing, and that too on me? But that's what we do. We have to keep abreast. We have to keep up with new developments. And we caring and what obstetrics is about. For me, obstetrics is about what its name means. Obstetrics comes from obster, which is to stand beside. And I believe that the art of obstetrics is about understanding and doing nature's job, maybe a little more efficiently, and maybe trying to avoid the points where we could have a patient getting into trouble. Women have to be in the center of our equation. And I believe that, again, if that's what we are doing, we can never get it wrong. Finally, I can't finish without saying something about Foxy, which is so special to us. And it's a privilege. Two other Secretary Generals of Foxy, CN, who's probably, I first came into an office bearer's post with CN. We achieved great things. And we achieved great things because that's how it was, And then, of course, CN gave me the opportunity of being the chair of the scientific committee of FIGO. And I'm proud to say, CN, that it is acknowledged as the best FIGO conference in history. And I'm sure it's going to be difficult for someone to overcome that. Foxy's 3 pillars, knowledge, fellowship, and service, is something Dr. Hansotia was very, very convinced about. This is knowledge, what we are doing today. People coming together on a common platform is fellowship, and I know there is a lot of service. A great job, Jaideep. Keep up the great work. I know these have been very trying times for our federation. And I think the fact that you and Alpesh have kept it going and achieved so much and made Foxy something that has been acknowledged at every level, national, regional, and local, is an achievement. When your hands are tied, when you can't, when your face is covered by a mask, and still to bring so much attention to your organization and then through that serve women, I think is amazing. And finally, young people. I mean, when I see these 4 young people you've selected as conveners, I know Foxy is in very safe hands. And we had inspirations. For me, my inspirations were Dr. Pandit, Dr. Parikh, Dr. Tang, Dr. Hansotia. You would look, Dr. Sunawala, you'd look to them for approval for all that you did. When I see this next generation, I believe that somewhere we got our succession planning right. And thank you very much for inviting me here today. I'm so looking forward to the presentations and the panel discussion. Thank you.
Thank you. Thank you very much, Nozer. I think everybody knows that Nozer is probably one of our most articulate, well-spoken, thoughtful advocates for women's health. And I'm not saying this only as a Foxian, I'm saying this in general as an Indian, as an Asian, and as a member of the global community for women's health providers. It's always such a pleasure to listen to Nozer. I have known Nozer since I was a resident in my second post in Wadia Hospital. And even when I was so junior, he never treated me as someone who was, almost a decade younger than him. I hope I'm not giving away any age secrets here, Nozer. And, that's really been one of his most fantastic qualities. My interest in hysteroscopy, my interest in work on safe abortion has all been inculcated thanks to him. When he really made abortion such an important part of Foxy's mainstream when he was the chair of the MTP committee. I still remember there was a time when Nozer, Atul and me used to do these MTP workshops all over India. And just for fun, we used to switch topics with each other because we had heard each other so many times that we could speak on each other's slides, at any given point in time. Of course, I also have the extraordinary credit of making Nozer switch to iPhones. I think something which Nozer, I hope you're still with. And also the very, very, very extraordinary credit of taking Nozer to the first disco that he ever went to. So at least Ruby has to thank me for something. So thank you, Nozer. You're such an incredible friend, you're the epitome of friend, philosopher, and guide for me. Thank you so much for being here. Thank you.
Thank you, Jaideep. And I'm gonna announce this on a national, platform. You got me onto the iPhone and the iPad, and I'm probably going to buy my first MacBook after all these years. And it's coming this week. So you finally did it.
Priyanka, please. Thank you.
Thank you, Nozer sir. Thank you, Dr. CN sir, for being here. And thanks, Jaideep sir, for spilling out so many secrets for us. And so now moving on to the scientific session proper. I would like to introduce the first speaker of the day, Dr. Jaideep Tang. He's going to speak on vaccination in pregnancy. Now, everyone knows Jaideep Tang, sir. Everyone has heard this Secretary General of Foxy, which is introduced whenever he comes to any talk or whenever he comes to any session. But I would today like to say over here that he is a person who has dedicated his entire last few years towards Foxy. He has given in so much. He is instrumental in starting the online voting for Foxy, which has received credits from like all quarters. So, sir is definitely the one whom we definitely look forward to working under in Foxy and to higher responsibilities as well. So, sir, I request you to talk on vaccination in pregnancy. I would hand over the platform now to you, and I hope it will be of great benefit to all our speakers. Over to you, sir.
Thank you, Priyankar. Just allow me a minute to share my screen. Right. I hope I'm audible and my slide is seen.
Yes, sir. Please go on.
Yeah. Thank you. So this is a very, very special O2S Masterclass series. I think it's the 8th one. And in fact, this is a very special one because of all the people who are involved in it. I've already spoken about CN sir, Nozer, and of course there is Krishnendu, a very, very, very dear friend of mine from Calcutta. Anita, who sir has just mentioned about. Then there's, of course, Kavita, Sujata, Dr. Datta Panandikar, Dr. Rajul, Kundan, Komal, and Sangeeta. A very, very special CME for me because of all the people who are involved, so many dear friends, so many guides, so many mentors. Let me begin my talk on vaccination in pregnancy by reiterating a little of the history of vaccines. And I think this is very important in the current context because we are now looking to a vaccine to pull us out of a pandemic, the likes of which we have not seen in our lifetime. And I say that because I'm quite confident that none of us were around in 1920 when the last Spanish flu pandemic took place. Of course, vaccinations are lifesavers. They have been responsible for one of history's greatest public health triumphs, which is the eradication and the complete obliteration of smallpox. And the fact of the matter is that right from the time since Edward Jenner and then Louis Pasteur and then Calmette and Verin and then Salk and Sabine, etc., made all those breakthrough contributions for vaccines, vaccines have come a long way. But vaccines have traditionally been seen to be the province either of pediatricians or of medical doctors, that is, MD physicians. But for obstetricians and gynecologists, I do believe that vaccines represent a unparalleled opportunity to protect women by building up their active immunity and neonates or infants by transfer of passive immunity. After all, we are going to be looking after patients for a very long time during their pregnancy. And we are therefore looking at a receptive population who are already in the health system. And it's a well known fact that acceptance is high when OBGYNs recommend vaccination. So what we'll do is we'll talk a little bit about vaccination in pregnancy in general. We'll then talk a little bit about COVID and its implications and the way the pandemic is panning out nowadays, and then round it up by the current recommendations on COVID vaccination in pregnancy, and with a few words about the current controversy on COVID vaccines. So, of course, we know that the tetanus toxoid was the standard recommendation for vaccination in pregnancy. And this was a very, very old kind of a recommendation. They said you can give it from the second trimester, 28 days apart. And the perspective at that time was that in natural disasters and war, the risk of tetanus is increased. And even if tetanus is relatively rare, when it does occur, it is lethal. The vaccine, on the other hand, was safe, effective, and economical and resulted in huge reductions in tetanus related mortality. So, when we were looking at our old national immunization schedule, that's what the schedule used to look like. But then we started getting all the new vaccines. And sometimes, to tell you the truth, I do get confused in this alphabet soup about capital D, small d, T, P, WP, etc. So just to clarify about that, the bacterial diseases are grouped together. That's tetanus, diphtheria, and pertussis. The terminology is based on the component, the quantity, which gives it the capital or the small letter, and whether it is whole or acellular, which gives it the W or the A. So W or A is applicable for pertussis. So for children, for example, you would have a DTWP vaccine, that's diphtheria, tetanus, and a whole pertussis vaccine. And for adults, you would have a TD and a Tdap vaccine. So that's, let's hope that sort of clears up this whole thing about why the letters are arranged and why they are in capitals and small off and on. Diphtheria vaccination is something which has come, I wouldn't say recently, but is being taken up more and more now. And the reason why diphtheria vaccination was added was that it was a misconception that diphtheria is a disease of infants and children only. In fact, since the last 2 decades, India has seen 4 major outbreaks with an annual mortality of 3,300, and a booster of diphtheria is certainly needed for adults. So this has led to the TD vaccine being incorporated into the National Immunization Schedule. So if you go and access the Ministry of Health and Family Welfare website, you will now see that TT, the old TT, has been removed from the National Immunization Schedule, and it is now TD, which is present everywhere as far as infants, children, and pregnant women go. The pertussis vaccine is important because infant immunization is not protective till around 4 months. Besides that, infants can get infected and have serious morbidity and mortality within this much time, in the gap in which they receive the vaccine and before it becomes protective. And more than 75% of pertussis deaths occur at less than 3 months. About 25% of infected infants get pneumonia or encephalopathy, and therefore, a good way to protect these infants is by passive immunity from the mother. And that is where the pertussis vaccine comes in for maternal immunization. So all the global associations like the ACOG, the RCOG, and the WHO, and I'm very proud to say FOXI also, do recommend the administration of a Tdap vaccine. Of course, we also now talk a lot about the influenza vaccine, and it is now recommended that an inactivated influenza vaccine be given as a single dose. It may be administered in epidemics. And of course, let's remember that the influenza vaccine changes annually, which is based on the viral strain. The rationale for providing influenza vaccine in pregnancy is that pregnant women are more susceptible to influenza. The likelihood of ARDS is higher, and it also confers protection to the newborn who are not to be vaccinated for this till the first 6 months of life. So if you look on this one side, you will see that that is the standard CDC recommendations, and it's a little confusing. So Parikshit has made this nice little chart on the side over here to talk about standard vaccination in pregnancy, where we give from 12 to 16 weeks TD, from 20 to 24 weeks influenza, and from 28 to 32 weeks, we give Tdap. So this is the standard protocol for vaccination that we now follow in our clinic. We have completely stopped giving TT and have added these vaccines since a while now. So what should be the duration between the two vaccines? There should be a duration of around 4 weeks. You can make seasonal variations for flu vaccine. If you're in the flu season, you can consider giving influenza vaccine a little earlier. And for late registrations, can you give TD or Tdap with the flu vaccine? The answer is yes, because the principle is don't administer live attenuated vaccines together. Which are the vaccines you should not use in pregnancy? All live vaccines like MMR, varicella, and BCG. But what happens if a woman is unknowingly immunized with these or becomes pregnant within 3 months of immunization? You need to counsel them about remote theoretical risks. It's not an automatic indication for MTP, but it does need a fair bit of counseling, particularly if the MMR and the varicella vaccines have been used. Some patients may need to travel in pregnancy and may ask for the yellow fever vaccine. In case they ask you for it, remember that it's a live vaccine. It has a theoretical transmission risk, and women should be advised to avoid or postpone travel. If the patient suffers from an animal bite in pregnancy, you could give rabies vaccine in pregnancy because it is life-saving. And in fact, you can also use immunoglobulin in this situation. Of course, when you talk about adding something to your antenatal package, there will always be concerns, and there'll be concerns of an economic burden and a change in practice. I would have to say that the benefits of adding the vaccination, like so many other vaccines, quite outweigh the risks of vaccination, both in terms of economic burden as well as in the hardship, if you will, that you have to face as a change in practice. Fake news is increasingly a concern. I mean, I simply cannot understand what these anti-vaccination people are going on and on about. for me, it is downright irresponsible if you are going to propagate that a vaccine is dangerous when it has already been proven to be safe. They talk about the MMR vaccine and autism and deaths from HPV. I know that in Japan, for example, the cervical cancer prevention program has taken quite a bad hit because of these kind of news. If a patient comes to you for pre-pregnancy planning, then these are the vaccines you should consider: MMR or MR and varicella. Remember that if this vaccine is given, you should ask the patient to delay the pregnancy by 3 months. For hepatitis B and HPV, there's no need to delay the pregnancy. Once the patient has delivered, of course, she can still be asked to catch up with the universal immunization program. And you should consider all these vaccines which are written here in case she has not had the opportunity to take these vaccinations previously. Let me sort of complete the talk with talking a little bit about the COVID-19 vaccine. You know, this whole last year, we all have been looking for that pot of gold at the end of the COVID rainbow, which is really the COVID-19 vaccine. And let me just give a little bit of perspective on the pandemic. You know, I remember when the pandemic started, there were all these projections, 300 to 500 million Indians getting infected and 20 lakh, that's a couple of million Indians dying, because of COVID. Well, fortunately, it has not turned out to be true. And I think one of the key lessons that we need to take away from forecasting is that forecasting always has a strong tendency to overpredict. And it's good that we are cautious. It's good that we keep the fact in mind that there could be several deaths and several problems. But whenever a forecast is made by an epidemiologist, it should be adequately communicated that these are forecasts. They are not written in stone and they are by their very nature uncertain. In fact, I read this quite interesting article by this Mr. Mondal, and he said that India is such a complex country that you possibly cannot apply one mathematical model for the entire country. He's saying that for every 100 kilometers, for example, circumstances in the country are so different that you need multiple mathematical models to make accurate predictions. And that has really been borne out. Now, these are statistics which I have taken today. The one on this side is from the Worldometers Info, which is a very, very popular site for getting information. And what I'd like you to see over here is where India stands in terms of deaths per either 100,000 or deaths per 1,000. You can see that India is very, very, very low. And in fact, I cannot say why India has done so well, but the fact of the matter is that India has done well in controlling and dealing with the COVID pandemic. To again give you a context, look at the last pandemic, the 1918-1920 influenza pandemic that we had. It infected a third of the world's population and killed 50 million people. So whenever we have pessimism, we need to balance it with pragmatism. And not only do we need to do that, we also need to accept the fact that sometimes there are people outside medicine who can contribute substantially to healthcare issues. For example, the scientists who have contributed so well to the development of the vaccine. I like this sentence: becoming enamored with one's own truth defines us as believers rather than scientists participating in the exploration of the constantly new. So let's talk a little bit about vaccines in general. And I believe that this is too basic for us to reiterate. But essentially, the vaccine teaches the immune system on how to respond in case a similar antigen is derived. And this is where a background in basic sciences and all the work which was done for the HIV vaccine, although we don't have an HIV vaccine, but all the work that was done for HIV vaccine in developing all these vectors has really come to fruition. Another thing I'd like to say before I conclude with some sentences about the COVID vaccine is our demand for stringency of data. We are trying to apply the same standards to the evidence For COVID, which is a disease we only became aware of in March, to diseases which have been with us for years and decades. I think it is simply unfair. At some point in time, we will have to accept that the evidence standards that we hold so dear cannot really be compared. And if you look at the way vaccines were developed in the past, and that's Albert Sabin, he says he studied the effects of his new lot of polio vaccine in 100 adult volunteers. And he was so happy with the results that he's now going to give it to his wife, children, neighbors, and so on and so forth. So one of these two models for developing the vaccine is incorrect. So you look at the old model here. 2 years for phase 1 studies, 2 to 3 years for phase 2 studies, and 5 to 10 years for phase 3 studies, with each phase answering different questions about the vaccine. So the phase 1 is essentially to know the dosage and to decide immunogenicity. Phase 2 is a randomized trial. The phase 1 is not even a randomized trial. Phase 2 is a randomized trial which looks at immunogenicity, route of delivery, dosage, and the immunization schedule. And then you have phase 3, which actually defines safety in a very large population. So if you don't have a phase 3 trial, does it mean the vaccine is unsafe? No, it doesn't. It means it's not been tested in enough number of people, but by no means does it mean that the vaccine is unsafe. And look at the number of years and the number of volunteers, and imagine the gumption of human science that we have managed to compress this process, which is supposed to take 14 years, into a period of less than 14 months. And that's the stunning pace of progress. 1 year in COVID-19 treatments and vaccines are already being taken all over the world. We have compressed 14 years of vaccine research into less than 12 months. And if we have done that, I think we have to understand that we really cannot be asking for the same stringency of data. So right now in India, these are the two vaccines which have been approved. There is the Covishield vaccine and the Covaxin. They are both quite different. The Serum Institute vaccine is the one which is developed in association with the AstraZeneca, and it uses a chimpanzee adenovirus. It's a vector vaccine, and the Bharat Biotech vaccine is quite different. It's an inactivated vaccine. Both the vaccines are safe as per animal and human studies, and both the vaccines have been shown to produce good immunogenicity, which includes both antibody and T cell responses. However, let's remember that we again cannot apply the stringency of evidence that we are used to over here, simply because this is still a very, very young disease. So regarding the controversy and the wording of the approval for both these vaccines, again, let's remember that they have been approved in trial mode. Trial mode simply means that it's not like a BCG vaccine where the patient comes, takes the vaccine and goes away. In a clinical trial mode means you need regular follow-up, you need counseling, and you need consent of all the persons who take the vaccine. Of course, let's not forget that even after approval, the vaccine has an extremely complex journey to the last mile. Fortunately, India is a champion, and there's really no other word for this. India is a champion at vaccination. India makes about 60% of vaccines globally, and India's existing vaccination program already covers about 55 million people a year, administrating 390 million free jabs against a dozen diseases. I dare say that the immunization program in India is probably going to be much more successful, much more penetrative, and much more deep than any other countries. Let's also remember that you don't need to vaccine 100% of population to achieve a good effect. Once you have vaccinated a certain percentage of population, you will already start seeing the beneficial effects of the vaccination. So let me round up by talking a little bit about these very sort of new and latest recommendations from the American College. The American College and the RCOG seem to have different views on COVID vaccination and pregnancy. The American College essentially says that so far, no adverse effects of the vaccine have been seen. And because of the way the vaccination is delivered and immunogenicity is provoked, It seems that the vaccines would be safe. However, we are leaving it to the patients who are pregnant to decide whether to take the vaccines or not. Whereas in the UK, the government has recommended that if you are pregnant, you should not be taking the vaccine. So it's a fairly fluid situation. We really need to wait for more data. It is my feeling as of now that if a pregnant patient can wait for the vaccine, we can advise her to wait. But if she is high risk for COVID because of some reason, then you can counsel the patient and go ahead and vaccinate her. So where are we now and how to move forward? We all know that it's the passive immunity from the vaccines, which not only protects the mother with active immunity, but also protects the fetus. And therefore, of course, vaccination in obstetrics is extraordinarily important. So let me end with this very nice sentence I read in Time magazine, which said, pathogens are mindless but relentless, but science is relentless too. And you have seen this in this absolutely stunning scientific spectacle of having a vaccine, which normally takes 14 years to develop, being developed in less than 12 months. Quite stunning, really, if you ask me. So again, thank you very much to everybody for attending. And I will look forward now to the rest of the webinar. In this webinar, we are very, very conscious of time. I'm sorry we are running a little late today. We are running around 5 to 10 minutes late. But I hope that the content will make up for it. Priyankur, can you
Yes.
introduce Krishnendu? Thank you.
Thank you, sir. You always, whenever you talk, you leave us in awe. And it was again a wonderful talk, sir. I would like to inform all our faculties as well as the delegates present here now that we are having 3,300 plus viewers who are there with us today. And that is the faculty is the sole reason that we have such wonderful attendance every time we do these sessions. And I would really like to thank Jaideep sir for the talk. And sir, I would definitely from the bottom of my heart would like to wish you all the best for when you contest for the coveted chair of president in 2023. All the best, sir. So moving on now, I would like to welcome our second speaker of today's evening. It is none other than Dr. Krishnendu Gupta, sir. Yeah, so sir is the professor and unit head of the Department of OBGYN, Vivekananda Institute of Medical Sciences. He is the adjunct professor in Kasturba Medical College from 2017 to 2022, Foxy representative to AOFOG 2020 to 22, chair of the Sexual and Reproductive Health Committee AOFOG 2019 to 22, chairperson of the ICOG 2016, president of the Bengal Obs-Gynae Society 2013, vice president of Foxy in 2011, president of ISOPAR Kolkata chapter 2015 to 19, and chairman of the Reproductive Endocrinology Committee Foxy 2003 to 7. I welcome you, sir, to this platform, and I would definitely like to say over here that for us here in Bengal, sir is a figure who really supports the juniors and gives us opportunities. So thank you, sir, for being in this platform today, and we are looking forward to your talk on nutrition and lactation. Over to you, sir.
Thank you very much, Priyankur. At the outset, I'd like to pay my respects to Professor C.N. Purandare, who's been really a great guide and mentor to me all these years in Foxy. And my grateful thanks to Jaideep and my respects to Noza too, and to all the senior teachers and colleagues, and of course, the moderator of the panel and the panelists. My greetings to you from Kolkata. Thank you for this opportunity. And Priyankur, thanks for saying these kind words about me. The topic that I'm going to discuss with you today is, of course, nutrition and lactation, nothing new. So I'm going to basically reinforce or rather make you re-aware of what you already know. And so that's going to be my job. And it's not a very interesting topic, to be very honest, but I'll try to take you on this little story and journey. Breastfeeding and breast milk are the global standards for infant feeding. And this is the statement by WHO, and of course, which is vetted by the American Academy of Pediatrics, the Indian Academy of Pediatrics, all the important organizations, including FOGSI, the American Academy of Family Practice, as well as the Academy of Breastfeeding Medicine. And the American Academy also of Pediatrics also recommend exclusive breastfeeding for the first 6 months and breastfeeding at least throughout the first year of life. So energy and nutrition requirements differ during lactation and breastfeeding, very similar to pregnancy. And we must know that women who are breastfeeding, they require approximately 500 additional kilocalories per day beyond what is recommended for a non-lactating woman. And this calculation comes from the volume of breast milk that is produced per day. That's about 450 to 1200 mils, and the energy content of the milk, which is about 67 kilocalories per 100 ml. So during pregnancy, most women actually store an extra 2 to 5 kgs, which of course works about 19,000 to 48,000 kilocalories in tissues, which is fat. And this is in the physiological preparation for lactation. So women who do not consume these extra calories, the body stores are then used to maintain lactation. So it is not unusual that we find lactating women actually losing an additional 500 grams to a kilo per month after the first postpartum month. So why is nutrition so important during lactation? It's because lactation is one of the most complex and nutritionally demanding phases of the human life cycle. The breastfed infant is still dependent on the mother for nutrition while growing at about a rate of about 150 to 200 grams per week. The muscle and nerve development are going on to allow the infant to quickly develop motor skills such as head control and grip. Cognitive development is also underway. The infant's senses begin to mature, and the brain is developing to process these sensory inputs. By 3 months, an infant may be able to lift his head, track objects, control hands and feet. By 6 months, he or she develops color vision, can sit with support, and is beginning the first steps of language development. So all these developments require nutrition. So all these extremely important that proper nutrition goes in. Some of these nutrients perform regulatory roles, some as structural components of nerve cells, and some even partake in the biochemical pathways within the cell. So to support optimal health for both the mother and the infant, it is important to understand and how nutrient need changes during lactation and the consequences of intake of inadequate intakes. So it is critical. This is a very important fact to be familiar with the typical dietary intakes of the lactating mother, so that we can identify what is missing, identify what we have to educate, and intervene to promote health. Almost all the nutrients have increased dietary requirements during lactation compared to pregnancy, and you'll be amazed to know that the calorific expenditure of 9 months of lactation can exceed that of the pregnancy by 98%, and that's really, really big. So similarly, requirements of most vitamins and minerals increase of varying degrees, which I'll come to later on. Some requirements only require increase marginally, like zinc or potassium, while others like vitamin A increase up to 69%. So if you have a look at this rather busy graph, what is shown in green is the increase in requirement compared to pregnancy that a lactating mother actually requires. And the red is decrease in quantity when compared to pregnancy. So you can see that the reds are rather low. Iron, of course, content requirement is less, niacin, folate, and magnesium, while the calorie intake, carbohydrates, fiber, fluids, vitamin A, C, E, all the B vitamins, potassium, iodine, zinc, selenium, copper, chromium, choline, all are on a much, much higher requirement in a lactating mother than when compared to pregnancy. And that is, you can see vitamin A is as high as 69%. So it's really very important that we plan the diet accordingly. So what are the nutrients which affect infant health? Now, breast milk concentrations of some nutrients can be altered by changes in maternal intakes or nutrient stores. And these are vitamin A, C, D, B vitamins, B12, iodine, and choline. And the important practice points for us clinicians is that when these infants are exclusively breastfed, who have deficient intakes, they may be at a risk of inadequate of these nutrients in them. Now, milk is produced when the mother is undernourished, but concentrations of certain nutrients may not be optimal or even sufficient for proper development under these conditions. So these adverse health outcomes associated with deficient intakes, of course, will vary from nutrient to nutrient. And in that busy slide, which I showed you regarding all what is required, other than basically iron, most of them are really required in lactation. Let's come to vitamin D. Now, breast milk concentrations remain inadequate even when the mothers meet their dietary needs. So the inference is the infant is at risk of developing rickets. Hence, direct supplementation of vitamin D is recommended for all breastfed infants, and the WHO requirement is 1.5 to 2 grams of elemental calcium per day. There's a loss of calcium in the breast milk, which is, between 280 to 400 milligrams per day. So this is because of the temporary demineralization of the skeleton, and also because the estrogen levels decrease and making the bones a little weaker. Iodine, a deficient intake of iodine can lead to abnormal brain development, and that is irreversible. So we have to be extremely careful with iodine as well. Vitamin A, as I said, the increase is as high as 69%, 7 times higher in well-nourished women than undernourished women. And low intakes of this vitamin A can give rise to subclinical vitamin A deficiency and can actually increase the risk of infection and xerophthalmia in more severe cases. DHA and lutein, and of course, this is something very important. We've been supplementing a lot, given the surge in the brain and nerve development. Docosahexaenoic acid, which is an omega-3 fatty acid, as we know, the DHA, and lutein have become a very focal point for neonatal nutrition research. And DHA is a major component in the brain and may have an important role in the cognitive development. And the supplemental dosing is about 200 milligrams per day. Lutein is particularly important for developing infants, and it is the main component found in the fovea centralis, which is the part where the eye is responsible for visual acuity, where all the cones are concentrated and it's under the development. So in case you have a lutein deficiency, the baby is going to have some visual disturbances. So breast milk concentrations for both these nutrients respond to maternal intake, thankfully, and allowing the mother's diet to influence the nutrition received by breastfed infants. So coming to now maternal health, we are talking about the infant health. So nutrients have breast milk concentrations which are not altered by nutrition status of the mother, like calcium, zinc, phosphorus, protein, and calories. The mother's body will ensure that there is sufficient concentration, thankfully, of all these nutrients in the milk at the expense of depleting maternal stores. So that's the most important point, that the mother has to, make sure that these depleted maternal stores are replenished. So inadequate intake of nutrients in this group will lead to health effects in the mother rather than the infant. And potential health effects are, of course, anemia, and of course, because of the decrease in bone mineral density, that is osteoporosis. And all of us are extremely worried about it, because thankfully we can detect the effects, but we know that they are actually public health concerns, even for women, even prior to lactation in our country. So it's extremely important to ensure that adequate amount of these nutrients and proper monitoring is done of both iron and calcium. And I think this cannot be overemphasized. So if you look at this again, a rather busy slide, but this is actually showing you that the nutrients which are in the breast milk, which are affected by maternal intake, the ones in green, which you can see are the large number of them. The blue are the nutrients which are in the breast milk, which are not altered by the maternal nutritional status, which is a few: chromium, zinc, copper, and calcium. Now, so what is very important, that the diet has to be balanced. So there has to be a proper effort to ensure that the lady gets adequate amount of iodine, vitamin D, of course, DHA, vitamin E, lutein, etc., going down all to the B vitamins, to ensure that there is adequate amount of growth in the infant as expected. So what are the practical problems? The practical problems we see is the lactating women are consuming inadequate amounts of food that are good source of nutrients, like fruits, vegetables, dairy, and fatty fish. Grains and proteins intakes are much closer to the recommendation. So therefore, you find that most of the B vitamins, other than the vitamin B12 in a vegetarian, they are most close to about 100%. So what is important is we have to focus that the correct diet is given to the lady, and that is a very, very important issue. So we all should be concerned. And as healthcare providers, I think we have seen how beneficial folic acid supplementation did. And it's been studied that there was a 173% increase in the median serum folic acid intake in the childbearing age when this neural tube defect issues came up and they were asked to supplement. So what is very important is not only we have to emphasize to the lady to increase the consumption of fruit, veggies, and dairy products. Of course, in a intolerant, lactose intolerant, it'll be difficult, but then we have to then talk about tofu and stuff like that. But what is the most important for us doctors who don't have much time, unfortunately, is recognizing and understanding the unique dietary needs of lactating women to target the proper intervention. So there are a lot of nutritional deficiencies which can give rise to problems, and the deficiencies of less calories, protein, essential fatty acids, vitamin A, vitamin B, the group, they can all give rise to a lot of deficiencies, which of course is beyond the scope of this presentation. These are found in any any important textbook. I've also given the references. I know that these are being watched, these webinars are being watched by a lot of postgraduates, and that's why I've given a lot of references at the end. They take a lot of screenshots, I know. So we have the clinical signs both for the mother as well as for the infant. So there are very clear-cut signs that we can actually make out that this baby is deficient in this particular nutrient. It could be a vitamin D, it could be iron, zinc, copper, etc. And then we can link the sign of deficiency. This is one of the most important and recommended reading that I would suggest to all the postgraduates. This was a recent review article published in Annals of Nutrition and Metabolism in 2019, which is Nutrition During Pregnancy, Lactation, and Early Childhood and its Implications for Maternal and Long-Term Child Health, the Early Nutrition Project details. And if Professor C.N. Purandare is watching, I'm sure it was done during his time of presidency, because there is a FIGO action points for healthcare providers. Actually, FIGO has recommended on how healthcare providers like us can actually work on the assessment of diet based on the based on the presentation of the lady, the history and everything, and point out the important and highlight the important points that can be discussed with the lady. So at a community health level, at a health worker level, nutritionist level, a family doctor, GP level, OBG, we should work on the kind of the BMI, waist circumference, etc. And of course, must discuss with them to get rid of not to stop using tobacco, alcohol, and recreational drug intake, etc. And of course, the midwives can also kind of guide the woman what to do, especially when they come pregnant. So these are some of the things which FIGO has taken it in a very big way. And I'm very glad that I can actually speak about FIGO when our immediate past president of FIGO is with us in this webinar. So what are the key points of nutrition and lactation? Unfortunately, there are even less evidence-based recommendations for nutrient intake during breastfeeding compared to pregnancy. Lactation is considered successful when the breastfed infant is gaining an appropriate amount of weight. The recommended daily allowance of protein during lactation is an additional 25 grams per day. Requirement of many micronutrients increase compared to pregnancy, with the exception of vitamin D and K, calcium, fluoride, magnesium, and phosphorus. It is recommended to continue to take a prenatal vitamin while the mothers are breastfeeding. A lot of them do anyway. Weight loss during lactation does not usually impact the quantity and quality of breast milk. Maternal deficiencies in magnesium, vitamin B6, folate, calcium, and zinc have been described during lactation. Both fat and water-soluble vitamins are secreted into breast milk, and their levels are reduced in breast milk when there is maternal vitamin deficiency, but thankfully, they are reversible and respond to maternal supplementation. Calcium, phosphorus, and magnesium levels in breast milk are independent of maternal serum levels and diet. Maternal factors, and this is a very important point, such as stress, anxiety, and smoking can decrease milk production, but the quantitative and calorific value of breast milk does not change with dieting and exercise. And it's very important to note that women's weight, BMI, body fat percentage, and weight gain during pregnancy does not, I repeat, does not influence milk production. So to summarize, nutrition needs during lactation are unique and one of the highest demands for good nutrition during a woman's life. Many breastfeeding mothers are not meeting the optimal nutrient intakes, as we saw. They're not having the veggies, the fruits, the fatty fish, etc. Of course, vegetarians can't have fatty fish, but we have to make up. Maternal and intake during lactation has potential to significantly impact both infant and maternal health. And role of healthcare providers like us is extremely important. And I've put the word certified in inverted commas because we have a lot of people who are just kind of brandishing themselves as nutritionists, as lactational experts. I don't know where the hell they get the degrees from. Unless they are certified, you must make sure that we cannot, kind of listen to them. We have to ensure that they are absolutely certified, because we all have passed our DGO, we have passed our MD to, speak in these webinars, to actually counsel a lady. So nutritionists are great, but certified nutritionists are definitely much, 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 much better. So there was a movie called The 100-Foot Journey about nutrition, about food. And I think the first 1,000-day nutrition matters, right from the first trimester, second trimester, third trimester, and then a large part of the lactation period, which actually we kind of don't give that much of importance as far as nutrition is concerned. As the calorific tally in 9 months it exceeds the pregnancy by 98%, as I highlighted. It's extremely important that these days of the lactating mother are taken care of. I will just end with this final thought about the developmental and metabolic programming, or the developmental or fetal origins of adult disease. And that's I think a chapter by itself, which we can give thought about in an hour. So we have to understand that there is a problem if we do not give adequate nutrition to the growing fetus, to the growing child. We are going to have problems later on in adult life. And a very apt saying by Confucius way back: one who does not think and plan ahead will find trouble right at her door. So if you do not take care of this lady's nutrition, if I don't plan the mother's nutrition, we're going to have trouble later on in life. And there are a whole lot of references. And one of the references which I must highlight is this book, which was written way back in 1991, called Nutrition During Lactation, is still considered as one of the Bibles of this chapter on nutrition during lactation. And I think it's a must read for people who are really interested in nutrition and lactation. Thank you very much for your patient hearing. I hope I could save some of the time, because whenever I see Priyankur hovering and looking at me and trying to smile, I know that my time is up. And I would like to thank Jaideep again for doing, for thinking of me and giving me this topic. And I really thank all of you with folded hands for your patient hearing. Thank you very much.
Thank you, Krishnendu, for a fantastic talk. I know you were a little apprehensive of the topic, but I can honestly say that you really did a fantastic job of it. Thank you so very much.
Thank you
for accepting and being a part of this webinar. You are right. Priyankur was glaring at me also when I was speaking, but I'm happy to say that we are only 7 minutes behind the time. And because we are 7 minutes behind the time, I think, Priyankur, it might be a good idea to dispense with the questions now. Although there are several complimentary comments in the comment box for Krishnendu and my lecture. We can dispense with that for now, and please go ahead with the panel 8 minutes late. And I'm sure you'll agree, 8 minutes late, given the current circumstances, is really not all that bad, is it?
We are actually before time.
Absolutely, sir. Considering the way the webinars go now, it's absolutely way before time. So thank you so much, sir. It was an excellent talk, and I would definitely say the 3,000 plus people who are there with us, it was complete justice to the time that they have spent with us, because both the talks were excellent. So, sir, there's a question for you, which I see over here in the Q&A box. And the question is, do you recommend drinking a lot of water? I mean, does that by anyhow benefit breastfeeding?
Well, frankly, we do. We always tell them, because it helps. See, hydration from hydrotherapy looks like the panacea for everything now. White discharge, you ask them to drink lots of water. Even during breastfeeding, we always someone who's dehydrated, it's going to affect to some way. Now, you cannot quantify how much it's going to kind of thing. But it's very important that hydration, I think, is one of the most important kind of therapies I have found, in which gets rid of a lot of issues.
Thank you, sir. I request our viewers, if you have more questions, please put it in the Q&A box. I have a question for Jaideep, sir. Sir, there's a question.
Actually, Priyankur, you didn't hear Jaideep. Jaideep actually requested you to go ahead with the panel because of the time issue. Questions, he wanted to dispense of the questions. So it's up to Jaideep, frankly.
Okay. Okay. Jaideep sir, then I'll take the question at the end of the session.
Yes, if we have time after the panel, we can take them. Priyankar, please proceed with the panel. But I'd just like to inform Anita and the panelists that as of now, we have around 3,353 people logged in to listen to you. And we are really looking forward to your panel. Thank you.
Thank you, sir. I would now request Tim Torrent to play a short video before we move on to the panel discussion. Saurav?
The triangle of B complex is essential for pregnant women in their dietary process, as while conceiving, women find it difficult to produce adequate levels of vitamins. With external supplements, they get their required dosage, which is ready for absorption and utility by the body. Vitamin D also is most crucial in pregnancy and lactation. For prevention from adverse outcomes, future risk to health of child, and maternal and fetal health during pregnancy. European Society for Pediatric Endocrinology confirms vitamin D3 2000 IU per day ensures adequate vitamin D status in pregnancy and early infancy. Vitamin D3 supplementation helps achieve the sufficiency and can be taken for a long duration. Calcium also plays an important role in pregnancy as its twofold requirement increases. Adequate maternal health is needed for fetal bone health, and as per the BMC Public Health article, calcium supplementation during pregnancy reduces gestational hypertension by 45% and preeclampsia by 59%. Effective management of pregnancy demands supplementation of prenatal vitamins. This supplementation provides protection against various defects that can occur during pregnancy. Shellcal XT provides protection against neural tube defects. It reduces the risk of preterm birth and congenital heart diseases. Shellcal XT contains 1250 mg of calcium carbonate, which is required to maintain maternal skeletal calcium. 2000 IU of vitamin D ensures adequate status in pregnancy and early infancy. Shellcal XT has 1000 micrograms of L-methylfolate. Journal of Clinical Pharmacology and New Drugs confirms that L-methylfolate helps in decreasing the risk of NTD by 72%. The methylcobalamin at 1500 micrograms improves pregnancy outcome and maintains normal folate metabolism. The additional pyridoxal 5-phosphate at 20 mg reduces nausea and vomiting in pregnant women. From preconception, pregnancy to lactation, Shellcal XT is a world-class product for vitamin supplementation. Shellcal XT has special coating technology and vitamin D3 in stabilized form. Shellcal XT helps to reduce the pill burden. Dosage of Shellcal XT is 1 tablet once a day. Each ingredient in Shellcal XT is coated separately, so there is no drug-to-drug interaction. Shellcal XT scored tablet gives dosage convenience. A healthy start leads to healthy mothers, and healthy mothers make a healthy generation. After all, every pregnancy is precious.
Thank you, Tim Torrent, for supporting us throughout this webinar series. Now, moving on to the most awaited panel discussion. So, to moderate this panel, we have Dr. Anita Kaul ma'am with us. She is the head of Apollo Center of Fetal Medicine, New Delhi. She has trained in fetal medicine with Professor Nicolets at the Harris Birthright Research Center in London. She has a main clinical interest at present at establishing screening protocols which are relevant to Indian population in aneuploidy screening, preeclampsia, and growth restriction. She is National Examiner for the Fetal Medicine Foundation, UK. So I request ma'am to kindly take over, and I would request the panelists to kindly introduce themselves before we take over. Ma'am, just for your information, Dr. Kavita ma'am, she was caught up in an emergency and will join us in 5 minutes. And Dr. Sujata Kaur ma'am got caught in an emergency and will not be able to join us. She has expressed her best wishes for this panel.
Thank you very much. Shall I start screen share?
Yes, ma'am, sure.
So thank you all very much. So much pressure hearing all the numbers that are there, but it really is a pleasure to be here, and it seems amazingly academic panel that we are doing. So may I request all our panelists to introduce themselves? Dr. Kavita is not there. Dr. Datta, what about you?
Can you, am I audible?
Yes, you are.
Yeah, I'm Dr. Datta Panandikar. I'm a gynecologist from the city of Thane, which is very, very close to Mumbai. In fact, we border Mumbai. And I've done my MD from the prestigious Grand Medical College, JJ Hospital. I worked with as a registrar with the chief guest of today, Dr. C.N. Purandare, and now I'm practicing in Thane.
Okay, and thank you. Welcome. Dr. Rajul Tyagi.
Yeah, I'm Dr. Tyagi from Lucknow. I'm an infertility specialist. I'm running a Javitri Hospital. I'm a director of Javitri Hospital and Test Tube Baby Central, Lucknow.
Right. So we look forward to your input with twins. I think we would interact well on that. Dr. Kundan Ingle.
Hi, good evening, everybody. I'm a chairperson of Infertility Committee, FOXY, and I'm practicing in Pune as an IVF consultant at Nirmiti Clinic, which is a center for assisted reproduction and infertility. Thank you very much for inviting me.
So welcome. Dr. Komal Chavan.
Good evening, everybody. I'm Dr. Komal Chavan. I'm chairperson of FOXY Medical Disorders in Pregnancy Committee, managing member of the Managing Council of MOGS, and I am attached as an honorary professor at HBT and R.N. Cooper Hospital and Medical College.
Welcome, Komal. I think I participated in your husband's program recently, right?
Yes.
So welcome. And Dr. Sangeeta?
Yeah, ma'am. Good evening, everyone. Myself, Dr. Sangeeta Rai. I'm professor in the Department of Obstetrics and Gynae, Institute of Medical Sciences, Varanasi. I'm ex-secretary of Varanasi Obs and Gynae Society and presently vice president of VOX. So I'm very much interested in high-risk pregnancy, though I don't have much more experience than you all seniors, but I will do my best. Thank you, ma'am, for the opportunity, and thank you, sir.
No, I'm pleased to see some obstetricians here. I was thinking we only have infertility people. But anyway, so let's start. Dr. Datta, why is it important to differentiate between DCDA and MCDA? Because this is a problem we still face. People say we are carrying twins. They don't say that we are carrying dichorionic or monochorionic twins. So why is that important?
Yeah, it is important because there are certain conditions which are very peculiar to the monochorionic twins, like you have the twin-to-twin transfusion syndrome, you have the single FGR, you have one of the twins which is growth retarded. You can have a single fetus IUFD. You can have the TAP sequence or the TRAP sequence. When you need to know the chorionicity to understand which of the pregnancies are at risk of developing these conditions which are peculiar to the monochorionic twins. And
But
that's why knowing the chorionicity, which is...
So you're right, but also dichorionic also...
Yeah, the dichorionic twins will not have, probably not have these conditions, but you can still get an IUGR and an unexplained IUFD with the dichorionic twins also.
And also the big problem of preterm births, which is there in twins anyway. So yes, I mean, definitely a very high risk. And as you can see from the graph, stillbirths are much more. And as Dr. Datta said, much more in MCDA. So the key thing is to differentiate them. So how would you differentiate them on scan? So maybe Dr. Rajul, because you do a lot of fertility scanning.
So by doing the scan, we can differentiate whether this is a monochorionic twin or dichorionic twin. And we have to look the intertwin membrane, and that is a amnion. So basically in monochorionic, this membrane get attached at placenta 90 degree, while in dichorionic, the attachment is little bit wedge shape. So you can see the lambda sign or you can see a T sign. This lambda sign you will see in the dichorionic, while T sign is in monochorionic. But this you can easily see in the first trimester. And its sensitivity and specificity of these sign in first trimester is very good. It is round about the 99% sensitivity and specificity.
Exactly.
While
So
in the second trimester, we have to look for the other things also. You have to see these sign also. You can see the gender, if they are the same gender.
But the reality is that in the first trimester, these signs are visible, but by the second trimester, you may not. So you're right. You would look at other things like gender and what else? I mean, physically see if the placenta are apart.
Yes, there will be two placenta usually in the dichorionic, one placenta in monochorionic usually.
But the point is,
sometimes they can be fusing placenta.
Yeah, but which may cause confusion. So if you're in doubt in the second trimester and you can't tell them apart, treat these pregnancies as monochorionic.
Monochorionic, yeah.
Until further notice.
Ma'am,
so let's
thickness
go on to some...
will also help. Ma'am, thickness of the dividing membrane will also help.
Well, it doesn't really. When you're doing ultrasound, you can't, because you're at the moment. It helps when the babies are born and the neonates look at the the pediatricians look at it. But in ultrasound, you can't. So actually, practically you can't do it. So the best time to scan and the best time to decide and assign chorionicity is the first trimester, because as Dr. Tyagi said, the specificity is so high. So going on to these cases, we had a 36-year-old MCDA twin, 18 weeks. As you can see, one of them was growing well, but the other one was growing really small. So the discordancy was about 44%. There were good fetal movements. But at 18 weeks, you have this really, really small baby, 143 grams. How would you manage the rest of the pregnancy? How would you counsel? How would you monitor? Would you think about termination? Kundan, do you have any thoughts?
Yeah, sure. I think first of all, we need to explain the couple, especially about the outcome of this small baby. That's very important. And the second part is the frequent monitoring, which is going to be required to monitor this particular second pregnancy. And being a monochorionic and diamniotic, even we have to explain the couple about if there is a sudden demise of one fetus, how it will affect the second viable fetus immediately. So we have to be really, really vigilant, and very close monitoring is required in this scenario. I think this is the first thing which I would really like to emphasize on. Now, would you terminate that is something which is, I think I leave this decision on the couple, but I think it's already 18 weeks pregnancy. If we can go ahead at as early as possible, say beyond 26 weeks, also probably we may intervene and salvage both the care, but the choice has to be left it out on the.
The only additional thing, of course, is that when you see these very small fetuses, you worry that could you be dealing with some aneuploidy also.
Possibly.
And as you understand, with monochorionic, if one has a problem, the other one would have, even if it's not manifested. So as you rightly said, we talk about aneuploidy, all these complications, as you mentioned, the fact that one baby could die, and that there may be a neurodevelopmental delay. So what is unique in actually monochorionic twins is this something called this sort of savior vessel. So in any placenta, and if there is unequal distribution, it's very surprising, unlike singleton pregnancies, where you know, if the fetus is deteriorating, it's deteriorating. But in monochorionic twins, sometimes even if they're very small, they kind of go on for a very long time just because they always have this savior vessel. So, I mean, speaking to this couple, they decided not to do anything. They did an amnio, it was all fine. And they decided to continue. So at 22 weeks, we had a more than 50% discrepancy. The Dopplers had got bad, and we now started seeing duodenal atresia. So now we have this small twin, 22 weeker, and we know postnatally it'll need surgery. It's doing badly. What should we do now? What are the options that we have now? Komal?
See, now we are in a catch-20 situation because we know that the fetus is just barely 22 weeks and the survival also is going to be not a very good picture. So really a counseling at this stage is the most important thing, and that is what we can offer to the patient. And the discrepancy is more than 50, which is really an alarming thing. And definitely when there is an absent end diastolic flow.
So do you think you'll be more inclined towards selective reduction? Do you think that maybe at
we
this
need
time
to
we
actually
should bail
counsel
out?
with selective reduction also. There would be a high chances that there would be some implications of that procedure on the normal twins also. So requiring a lot of counseling and talking to the patient that there is a expectant management with a less favorable outcome. A selective reduction would help in this case. But the second fetus also may be somewhere compromised.
Because
Yes.
the main risk is of miscarrying the entire
Miscarriage
pregnancy.
is very high at this stage. At 22 weeks, we cannot offer them a proper salvageable fetus. So we need to counsel in that way that this is what we can still offer and we can try, wherein there would be outcomes in the best of the hands. And definitely that is the only option which is now remaining.
And what about the fact that if, say, you choose selective, I mean, where are we legally with these late twin reductions? Sangeeta, to anyone, any of the panelists, give me your views on
It's a
this.
very, very tricky situation right now. I think,
Controversial issue, ma'am.
no, I think we have to be very clear to the couple that the prognosis is really, really going to be bad and it's going to be on the worst side. We must prepare the couples for such a worst outcome. And I think what you rightly pointed about late selective reduction, I think medico-legally, we don't have this permission beyond 20 weeks till now, but I think...
No, but it's not exactly for twins, is it?
Yes.
It's for singleton, is it
24
not?
weeks.
Because I thought that if the pregnancy is continuing,
Then
we
it
are
is not
not
called as an
actually
MTP.
we're not
So,
under the PCP
Here, this doesn't come under an MTP Act at all because we are not doing an termination of pregnancy. It is like we are making a selective fetal, we are creating a demise. So definitely here we are doing it because it is a part of a procedure what we offer to the patient, because we know that
because it's a gray zone, maybe
Gray zone.
we can still go ahead and
we can still go ahead because MTP Act has never mentioned such cause, and definitely there are it is out of discussion here, but 22 weeks also when there is an anomaly with a fetus and with special permissions, MTPs are happening. We do get reference in medical college where we are doing MTPs for anomalies. So I think this is in the gray zone, but I think we need to handle it in a very good paperwork and all that manner.
You want to add some?
Yes, we have to keep it in mind about the monochorionicity. That's very, very important. Even we go for a selective embryo reduction.
But you know, there are ways of doing selective reduction. I'll do that later. But the point is that are we just? I mean, legally, have we got any standing? I think it's still a gray zone. I hope it continues to be a gray zone, and we don't get any direct. We don't get any directives as far as this is concerned. Maybe Foxy can take it up later on. But anyway, I think that, you know, you can't not offer what is the right thing for the patient in this very sort of typical situation. So our patient chose to continue, and they had expectant management. As you can see over here, the small baby is growing really small, and it continued till 33 weeks. So it is surprising how much you can take these monochorionic twins over, even if they're small. But what they were very clear is that they would choose compassionate care. They were not going to sit there and go ahead with surgery and so forth. The umbilical artery at 33 weeks had gone really haywire, and the ductus was looking bad. So covered them with steroids, and they delivered. And I thought that on these kind of ductuses, this baby is not going to survive very long, and that's what we told them. And they were very clear they didn't want to resuscitate. But the problem was that this small baby did not die. And we had the neonatologist saying, so we were in this situation where the parents did not want the baby, yet it was breathing quite okay on room air. So I'm just wondering, what do you think are the rights of the baby? I mean, over here, it's like parents want something, but the baby is doing well. What do you do now? Do you believe that baby has any rights? The fetus, we're still debating.
The baby does. The baby does have rights, and if a baby which is doing well and breathing, maybe on support or on no support, the neonatologists today are very clear that you cannot do anything to see that the baby dies soon. You have to continue your support till a time comes when the baby doesn't hold on to the support anymore. Yeah. So irrespective of the gestation or of the weight, or of the anomaly that the baby is carrying.
But the problem is we are a private hospital, and these bills were mounting.
Yes, correct.
So that also was the other issue, and the baby needed surgery. But I have to admit, the neonatologists were very helpful. They got an adoption agency involved. They said that they would take it, but it was a very, very fraught time. So sometimes they surprise you. Going on to a second case where this was a DCDA, IVF conceived pregnancy, now 19 weeks, and came with intermediate risks for trisomy 21. So 1 in 800 and 1 in 600. One of the twins had a intracardiac echogenic focus. The other one also had a hyperechogenic bowel. So in this situation, 19 weeks, would you do anything? Would you offer invasive? Would you do a cell-free DNA? What would you do? Dr. Rajul Tyagi?
I think we will go for amniocentesis.
Why won't you do a NIPT?
Yes, you can go for NIPT also.
No, but we have to decide one or the other. Why would, but would you agree that in twins we can now offer a cell-free DNA? So now you can actually, because cell-free DNA, it doesn't work as efficiently as in singleton pregnancies. I mean, it works very well in singleton pregnancies. It doesn't work so well. And the other problem is that in twins, the recall rate is very high. The fact that they can't give a result is very high. So the percentage of no results is much higher in twins. There's increased risk of test failures in IVF conceptions and dichorionic twins. So actually, you're right. It's not a good thing to do to offer to offer cell-free DNA in these kind of situations. And really, amniocentesis is the right thing to do. And also because it is a dictum that if you see any ultrasound findings, as we had in our case, we had the intracardiac echogenic marker, we had the echogenic bowel, it is better to do this. So amniocentesis indeed was done. All the reports were normal. But you can see that this baby is not growing. So if you look at it, this is the small baby and this is the normally growing baby. And now we were on a dilemma at 30 weeks that you have a reversal. The baby weight is about 560 grams. The other one is 1300 grams. Now, should we deliver or should we just manage expectantly? So what are the pros and cons of each situation? Sangeeta, you haven't spoken. Tell me.
Yeah, ma'am. So in these cases, it is a very dilemma situation because when we go for expectant management, the chances of intrauterine fetal death of the smaller twin is much higher. And in that case, the surviving twin has got the risk. So we have to do the counseling for the parents and with intensive surveillance of the fetus with proper monitoring by
But say
NST,
that
BPP,
this small baby
Doppler.
is roughly 560, 600 grams at 30 weeks or so, or 31 weeks.
Yeah.
What would you say would its chances of survival be in your nursery? I think it's important to know that can your nursery handle it? But 31 weeks would be considered a reasonable time to deliver. What do the rest think? What will all the panelists do? Dr.
We will
Datta,
do
what
the
do you
steroid
think?
coverage. First of all,
Yeah.
we will do.
Right.
First of all, we will give the steroid coverage,
Correct.
and we will see our nursery backup. If
Right.
our nursery backup is okay, so we will do an intensive monitoring. We can do daily color Doppler study and MCA and all.
Right. Yeah.
And then if it's going wrong and not in a proper way, then I will like to deliver because.
Okay.
And
What about you,
I
Dr.
would like
Doppler of the smaller twin, and
Right.
then decide our management plan.
But this is the Doppler of the smaller tin. It is
Yeah,
showing
yeah.
reversal. The
I think
ductus
that
is
is something
showing
very
a-
important
So it's
finding
like
here.
a pre-terminal Doppler. For us, it's a pre-terminal Doppler.
Okay.
Yes.
Then we
So
have to
the
deliver
point
that
is
by
okay,
steroid coverage.
right? But do you? I mean, if you look at the epiphage studies, sorry, if you look at the epiphage studies and you counsel, there is a risk of intraventricular hemorrhage, there is a risk of periventricular leukomalacia, of bronchopulmonary dysplasia, of neck, of lots of things.
Yes.
But other than that, there's also the cost of nursery care. I mean, even in our hospital, 600 grammar is something. If you talk to the neonatologist, they're not going to give you 100% outcome. So are we justified in delivering a baby and having the second one preterm for a baby that we're really not going to be able to salvage very well? I mean, I'm not sure.
I would probably give a different perspective.
Right.
The pregnancy is 31 weeks. It's around 1300 grams. If I can carry on.
Oh yeah, right. It's 1300 grams. So that twin is doing well.
Normal twin, and would probably give a better chance of survival to the normal twin, knowing very well that the smaller one may not survive even if I deliver it immediately.
Right. So
I think
would you prefer expectant management?
Yes, a good counseling of the parents, making them understand the cost of NICU care for a 560 gram baby, and with the chances of non-survival, and probably expectant management for a week or two, where the other twin will probably reach 1.5 kg and have a better chance of survival.
Correct. So indeed, this is what was done with ours as well. By the time we counseled her, the mother was very sure that, I don't know why my slide has stopped moving. The mother was very sure that she was okay. She would take the risk of IUFD. And the next visit, we saw that the baby had indeed, we'd lost the baby. God, my slides have got stuck. So now how would you manage a dichorionic? I mean, what is the kind of maternal surveillance? What's the fetal surveillance that you do when you've got a single fetal demise in a twin pregnancy? Komal, what would we do? You know, you got a dichorionic twin, 31 weeks. We've got one single fetal demise, but we have planned to continue. Is there something you do particularly different or not?
Yes, obviously now the patient comes first is that there is one IUFD fetus with a demise and one normal fetus. We know that there would be problems in this pregnancy. We need to monitor this pregnancy. Need to keep a close watch, as in weekly or ultrasound serial scans, and also do her coagulation profile and find out if there are any problems which a second of the twins is encountering, because the demise has happened late in pregnancy in the third trimester.
I think we will go
So
for
regard to
neurosonogram.
that, we are in a better, in a better age now, because it is 31 weeks is already crossed, and we have just to reach the age of viability at 34, or we can pull on.
Not really, because the thing is, once you've got a singleton, it's now in effect a singleton pregnancy.
Yes.
And in dichorionic, you would manage it as a singleton
As a
pregnancy.
singleton.
Yeah.
So
Only
You can go till
I'm
term,
worried
ma'am.
about the
not
labor, because it's a twin A which is now a demise. So during
it
labor,
doesn't matter. It doesn't matter. In dichorionic, very clearly the chances of the co-twin having problems
Much
is
better.
negligible, including brain and all the rest of it. You would aim to take this pregnancy as far into term as possible. You
Yes.
manage it like any other pregnancy. There's a very rare complication of aplasia cutis, which I'll tell you about in a minute.
But we
So
will like to do a
for some-
neurosonogram also.
So the neurosonogram actually is more for the monochorionic twins, because
That's
in
right, that's right.
monochorionic twins, I mean, we'll come to that in a minute, because in monochorionic twins, you need to look for brain damage, but in dichorionic twins, you don't. And I really want to clear these fallacies that obstetricians have in the audience, that there's no case of coagulopathy. I don't know where this has come into obstetrics.
We have been
There will
practicing
be
it
coagulopathy.
since long. We have been practicing and doing it.
No, but that is wrong, because of the fact that I'm sorry, there's something wrong with my.
Yeah, it's going backwards.
It's going. So what do I do? Can I mean, it's hung for some reason. So anyway, the point that I want to make.
I think, madam, you have to come out and log in again. Get the presentation out and put it again. It will start working.
But I'm just sort of
Stop sharing and share again.
Yeah, but my cursor
yes.
has gone up. But anyway, to get back to what I was saying is that there is no coagulopathy, there's no risk of infection. Okay, thanks. There's no risk of infection. So these are fallacies that that have now occurred because of dead freeze. There is a increased risk of preeclampsia. You should make sure that the anti-D is given if she's a Rh negative woman. And yes, you do a coagulation profile, you do fibrinogen, but otherwise dichorionic pregnancies with a single fetal demise is not an issue. Our lady continued. We looked at her, she maintained normal interval growth, there was good like a volume, but she had a section at 36 weeks, even though we were really against it. But I think it was partly the psychological problem also that these women have, that they're carrying a dead fetus. So as soon as she reached 9 months, she chose to deliver. This is a common problem, and here we will talk a little bit about the neurological problems that you were mentioning, Dr. Tyagi, that it is a twin-to-twin, as Dr. Datta was mentioning, where you have a poly and you have a small amniotic fluid. And here there was a single fetal demise at 27 weeks. So what would you expect in MCDA twins vis-a-vis DCDA twins with a single fetal demise? So Dr. Tyagi, you were mentioning,
outcomes is
the
more adverse.
twin is at more risk.
Right.
Is prone for preterm labor, demise, and then this neurological neurodevelopment impairment.
Absolutely.
So we will go for
and
neurosonogram.
Correct. And the reason why all this happens is for the reasons that Dr. Pandikar said earlier, is because of the placental angioarchitecture. all placentas of these MCDA twins is a single placenta, and what is unique about them are these connections. And if the connection is big and it is going sort of in a single direction, you have this so-called twin-to-twin transfusion syndrome, that one baby bleeds into the other one. One baby is like a IUGR baby, it's very small, and the other one is a poly. If the connections are really tiny, so the large connections give you TTTS. If the connections are really tiny, then there's chronic bleed. They're not these acute bleeds that you have in TTTS. And then you have something called the twin anemia polycythemia sequence, because the baby has time to adapt. So the baby has time to become polycythemic because it's receiving blood and it's got time to adapt. And if there is unequal sharing, if you've just got a small portion of placenta of one twin and a big of the other, then they have the selective fetal growth restriction. And as you all mentioned, these are the problems. Now, why? You know, this is something that I really get very upset with the obstetricians for. They feel that if there's been a single demise, they should deliver. Why shouldn't you deliver? Tell me, you know, one of you, tell me, why shouldn't we deliver if you have a single fetal demise with the MCDA twins? I mean, the reason, as we mentioned, is because you cannot stop the bleed. You know, no matter, even if you deliver them 1 hour after, first, you can never time when that baby died. And even if you deliver them 1 hour afterwards, when you have a drop in pressure in the dead twin, the other healthy twin, through these open connections, bleeds into the dead twin, and then it normalizes. And when this pressure drops in the healthy twin, you have cranial hemorrhage. And you know, you cannot stop brain damage, no matter how soon you do it. So please, the obstetricians, do not sit there and deliver it immediately. You are just adding preterm complications of preterm delivery to already a fraught situation. So it's best to wait and do what Dr. Tyagi has been saying. Look out for neurological problems. You need to do a neurosonogram and keep checking that is there a possibility that there's been any intraventricular hemorrhage, is there leukomalacia, are there cysts, whatever is falling. And this you can do by scan. So you keep scanning them every 2 weeks. You also do an MRI. Even if things look okay, you still do an MRI. And only after 6 weeks, if the MRI is showing no ischemic damage in your co-twin, can you then say that this baby is okay, and, you know, just go ahead like a singleton pregnancy. If at any point it shows brain damage, then at that point you need to, you know, counsel the parents and say that you're going to do it. What you do if you deliver is you'll still have a baby who was going to go ahead and have brain damage, will already have brain damage. So really you shouldn't. So can one of you kind of summarize our surveillance in DCDA versus MCDA twins? Because it's very clear, you know, DCDA doesn't need a lot, but MCDA needs much more intensive surveillance. And these are, so now we know that they've got much more complications. So what is the correct antenatal protocol that we need to follow in MCDA twins? So what would you do more in MCDA than you would do in DCDA? In how often would you want to see them, or at least have them scanned?
I think especially if we want to assess the blood flow, especially for the babies, I think color Doppler should be done at least every 2 weeks for the close surveillance.
Yeah, that's
especially
true.
MCDA, what I'm talking about.
Right.
And a growth you can just monitor every 4 weekly. But I think the Doppler, which is very important, it has to be every 2 weekly. So that's very important.
Correct, because you are trying to look for problems and you're trying to pick up these problems. So though it is very difficult, it is literally you're scanning them every 2 weeks to look for problems, so that if it comes up here, there is fetal therapy, and if it comes later, at least you have the choice of delivery.
Delivery.
Yeah. So So this was a case of TTTS. Can anyone describe what is TTTS and what would you expect to see on ultrasound?
And basically, twin transfusion syndrome, it is a severe complication of monochorionic twin pregnancies, and which
Correct.
is basically due to imbalance in the placental vascular anastomosis, such as there is a flow of blood from the donor twin to the recipient twin.
Correct.
Basically, when we see it into the placenta, the superficial, there is arterial and small venovenous anastomosis, and this is bidirectional flow. But the
That
deep
is true.
arteriovenous anastomosis is unidirectional flow, and which is
Right. So
balanced by this
as we saw,
superficial
but on
anastomosis.
ultrasound, because
Yeah,
you cannot see the placenta on ultrasound. So what
yeah.
should the obstetricians and the sonologists be aware that how will they
Um,
recognize there's TTS happening? Because as
Normally,
you
I
By
say
the
said,
quinto
amniotic
staging.
fluid, which is very important. Amniotic
Yeah,
fluid volume.
Yes, one
The
is
donor,
poly, one is oligo.
yeah, the
polio and
donor
oli.
filters
would you
should have a
agree that
oligo.
over
As per
here
the
you can see a oligo, sorry, a poly twin, and the donor twin, which is oligo, tends to be stuck on one side.
Yes,
We
yeah,
call it
yes,
the stuck twin.
yeah.
And
The sac,
and
bladder sac.
right. So when and you know that there is a staging that's called the
yes,
Quintero
Quinteros
staging, right?
staging.
Do any, can anyone enumerate?
Yeah. So
Yeah, this
Quinteros
can be
staging is
Quintero
given.
staging.
Staging.
This is,
Yeah.
Komal was telling me
yeah.
something. Yeah.
Yeah, so Quintero staging is a common what we follow, and it is divided into the 5 stages. That is, stage 1, when you actually take the amniotic fluid volume in the vertical pocket, and if it is less than 2 in the donor sac or more than 8 in the recipient sac, that is stage 1. And stage 2 will be when the fetal bladder there is a non-visualization in the donor twin, and you see it for a minute,
And the
and then you
reason for
don't see
that is
it.
this baby is giving so much blood to the co-twin. There's not enough renal perfusion, so
Yes,
it's not making urine, so you have an absent bladder. Then what's stage 3,
yes.
Komal?
Stage 3 is there is an absent or a reverse umbilical artery diastolic flow or a reverse ductus venous flow. So that is the stage 3. And stage 4 is the fetal hydrops in one or both the twins, and stage 5 is with fetal demise in one or both.
Correct.
So
So where
this
would
is
you
what
treat? I mean, what is the definitive treatment for TTTS? What would
definitive
you
Laser
treatment. The
ablation.
management options are the whatever what we have is the fetoscopic laser ablation or the amnio drainage, which is commonly written that when there is a poly or you have
No,
to
no, no,
drain.
no, no. But you are right when you say that laser is the correct thing to do. And I know people do amnio drainage, but that's not the right thing to do because you're not treating the pathology.
Yeah.
As Sangeeta was saying, you need to treat the pathology. You need to sit there and separate out these blood vessels. And it is this is what it looks like. So if you look at a placenta, when you do a fetoscopy, you go onto the placenta, identify the vessels, identify where they are sort of fusing, and remember, because of the absolute, I mean, the Achilles heel of any fetal therapy is preterm labor. So the bigger your instrument, the more chance it is that you'd go into preterm labor. And therefore you want really tiny instruments. And when you have these really tiny instruments, you cannot see everything. You have to do it piecemeal and you need to look for it. And then when you see the connection, you use the laser and burn it. So where would you use, we discussed selective reduction in MCDA twins. So for TTTS, of course, it's that is the definitive procedure, but there are some cases like, for instance, it's hydropic. Maybe we don't have so much time that we may use a selective reduction, but what are the other procedures you can use for selective reduction?
Yeah, you can use the bipolar diathermy, and you can use the radio frequency ablation also.
Right.
The radio frequency ablation, the lead is costly, so it can turn out to be a little costly for the couple. The bipolar diathermy is much cheaper.
Correct.
And only thing that when you catch the anomalies early in pregnancy, laser acts the best for early pregnancy, because the cord is sometimes very difficult to catch that early.
Right.
But once the cord is big enough to catch, then the bipolar diathermy works very well for selective fetal reduction. And I just wanted to say one thing about the Ventro classification, that the classification has a small fallacy, because the grade 1 doesn't guarantee you a good outcome for the baby, and sometimes the case can progress from grade 1 into grade 5 without going through grade 2, 3, and 4.
Very, very
So
true.
that's what you can
That
see.
is,
Have a
yeah.
sudden you can have a sudden
Which
fetal
is,
death.
yeah, and which is why we are so insistent that keep checking every 2 weeks, so that
Exactly,
if
exactly.
suddenly it drops, it goes through. And as you rightly said, because bipolars are really cheap, it's there in everyone's OT. It's the same Valley Lab, whatever we use for normal thing, it can be used. But as I said, the Achilles heel is preterm labor, so we always
Right,
worry
yeah.
about that. So now coming on to another case, 16-weeker. Now this is another DCDA who had a discordant anomaly. So she came at 16 weeks with a dysplastic tricuspid valve, everything normal, and you'd agree that things are looking pretty bad. I mean, it's really quite bad. Now in this situation, where you know that it's a lethal abnormality, would you offer selective reduction or would you just wait?
We will offer a selective reduction.
But it's a lethal abnormality. This baby is going to die anyway. Why will you want to interfere and add to the risk of preterm labor? I'm just giving you an opinion. Why
Yes,
would
a different opinion.
because the thing is, every time you stick an instrument in the uterus, in a pregnant uterus, you risk premature delivery. So in this particular case, which is a lethal abnormality, where you can see that things are looking really bad, and this baby is never going to survive, would you sit there and do it, or would you sit there and think that, well, because the risk of preterm delivery anyway is so high, maybe you should maybe you should sit there and offer?
You see, if we have to do something, if we have to plan to intervene, we should do for the benefit of the better twin,
Right.
not taking into consideration the twin which is already compromised. So I
Right.
definitely get that thing. If there is a severe lethal cardiac anomaly and it is going to anyway, the fetus is so much compromised and not going to survive. If there are any implications you feel that in that pregnancy, if there is any evidence of twin transfusion or any
So this is dichorionic. So dichorionic.
So I don't think there should be any issues in this when this fetus has any problem, because other fetus is normal. So I think we need to outweigh what are the benefits what we are going to achieve by doing a intervention procedure. And I think waiting and approaching and monitoring the normal twin is what is in our hand. That is the need of the hour.
And if, say, one had chosen reduction, which is the best time? Say you find a discordant anomaly, which is the best time to do an
As early as better, because
as early as better.
as early as at 11 week or before 13 week, I think that is the ideal time.
Yeah.
If want to do anything.
So yeah, as soon as they cross 16 weeks, as you can see, the loss rate really increases, of preterm delivery increases, of general loss increases. And she was like 16 weeks and some days. So we waited and again reviewed her at 20 weeks. Things looked bad, and this baby wasn't dying despite the fact that we thought that it's looking really bad. At 23 weeks, this baby wasn't dying. We asked our the ped cardiology lot, like, could they ever estimate? And they said they never see babies through in utero life. They see them at the end. So they couldn't help us very much. So we carried on, but then at 25 weeks, she developed acute polyhydramnios. The cervix really shortened. We had to do an amnio reduction because she had so much respiratory embarrassment and she went into preterm labor. So even though we did reduction, she went into preterm labor, delivered at 27 weeks. And that, the fetus eventually, that tricuspid dysplasia eventually died at 26 weeks. But by that time, she'd gone into preterm labor, and, this baby eventually died as well. So it's a very, as you said, a very tricky situation.
Yes,
What about
ma'am.
in this case? If you have an anencephaly,
Yes.
You
In
have an
these cases,
anencefali where you know that this is going to have
We should
polyhydramnios.
go
Yeah.
for we
We
should
should
go
go
for
for
selective
selective
reduction.
termination
And
to
Selective
minimize the risk.
what would be the technique that you use?
This is
So
called laser ablation.
Injection.
Because this is
No, you
monochorionic.
can't use KCL because these
No,
are
because
Now, in
monochorionic,
monochorionic, we should
you
not use
can't use
KCL.
KCL.
We can use laser ablation or cord
Laser
occlusion.
ablation.
No, but laser ablation, you cannot do at 12 weeks. The instrument is too big. The instrument which you do a phytoscopy is a 3.5 mm. It's like your hysteroscope. We cannot, the membranes are not fused. You
Can go for cord occlusion, ma'am.
The cord occlusion is the same thing. If you use the bipolar, it's too big. So what we do is we use interstitial laser. So that's a needle by which you put a single fiber. It's much smaller. It's thing. Of course, by the time you've counseled them about co-twin demise, etc., risk of miscarriage, I mean, we have some experience with interstitial lasers. They've done well, so we are quite happy. The ones where they didn't do well is triplets. So if there was a monochorionic triamniotic pregnancy, that means with one placenta but multiple sacs, they're the ones which had a problem. We did have one complication of aplasia cutis, which is this, which can really scary because it looks like burn marks. But this is because of that dead tissue which was left around. But I'm happy to say, it's sort of fading away. But this particular lady, by the time she was explained what are the problems, she said she would not do anything. So then she just carried on as normal, came at 29 weeks with respiratory huge poly. So at this time, nearly 30 weeks, where you think that she's going to, the cervix is barely, 13 mm. Would you sit there and deliver her? Or would you say that, okay, just carry on, let's do whatever we can? What would you do?
I think in this scenario, I think we can give her tocolytics in the form of progesterone to wait and watch for this kind of patients. But I think if it is a very short cervix of 13 millimeter, I think we have to tell them that the chances of preterm labor are very, very high.
Would you put a stitch in all of your twin pregnancies? I know the IVF people tend to be much more proactive about putting in a stitch.
Never.
No.
Would you do like ultrasound serial scans? Look at the length of the cervix.
Yeah.
Do that, but not going to help.
Anyway, in her case, we decided again to do an amnio reduction, explained everything, again drained out 200 mils, and she, unlike the last one, actually carried on. And then she finally delivered at 36 weeks. So I think that because we need to summarize as is 9 o'clock, what would you say is the key message, all of you, if you have to tell our thing, what would you say is our key message away from a sort of...
Correctly diagnose the chorionicity first.
Yes.
Yeah. Because it makes such a difference. And the fact that, the antenatal protocol is different, 2 weekly, I know it's difficult, but really it's sort of every 2 weeks, these MCDA twins need to be assessed. Monthly from 20 weeks onwards, the DCDA. This is just a summary of things. We know that there's more fetal anomalies in twins than there are in singletons. First trimester screening is the best thing that you can do for them. Lots of times, there's no right answer. It's like a dilemma. You need to discuss everything. Ideally, MCDAs need to be under fetal care, fetal medicine units. There's much of a muchness in the kind of procedures you do, but there is a lot of options available. The timing is tricky, but as all of you said, the earlier, the better. And I would like to thank all of you, the panelists, as indeed.
And I want to add, ma'am, that all the obstetricians, we should identify the complication first and refer them to a fetal medicine expert.
Right.
That is most important.
That's very good. But in Varanasi, I think we're struggling to
yes, ma'am. That is the reason.
I think one more take-home message is that to do all your ultrasounds on twins, you need a very well experienced sonologist to pick up the signs of anomalies or early TTS.
Well, I'm absolutely committed to obstetricians doing their own scans, and I think we are the best people to look for problems, and I think that we should be scanning more and more of our patients.
Yes.
So maybe the next generation.
Luckily in Thane we have Dr. Nitin Chaubal.
He's excellent.
So he's an excellent.
But nevertheless, the next generation, Dr. Panand,
yes, correct.
as in all your students and things, we need to teach them how to scan. Komal, any last words from you?
Yeah, I think everything is covered to diagnose it as early as possible. Knowing the chorionicity is the most, and it is a key in managing a patient with a twin, because it solves a lot of problems. A lot of problems can be picked up at early, managed early, so that we can give a favorable outcome to the patient. And also, it's important even to make realize, because the chorionicity goes on in longer run. Even the patients also get very touched, because they also want to know whether the twins are monozygous or dizygous. The bonding and a family and the social implication also comes. So all depends upon knowing the chorionicity, and the earlier we know, because it is easy to know it earlier, and then later on to wait till the
plan
So all that, so everything, I think the key is to know the chorionicity, and you hit the right and the short message, but the perfect take-home message.
Sundar, you?
I think it's once we diagnose this chorionicity, I think teamwork is the most important. So please involve and be in constant communication with a fetal medicine consultant and your neonatologist. I think it's a teamwork for all three units has to work.
Very true. So let's thank Dr. Tank and team, Priyankur, all of you for coordinating, and I'm handing over now to you. And thank you all very much. I really appreciate. I know I wasn't very communicative, but it's my inefficiency. So thank you for bearing with me.
On behalf of the panelists, I thank you, Dr. Anita Kaul, madam. I think you are one of the first persons to start and to introduce fetal medicine into India. And Dr. Purandare praised you a lot at the beginning of his talk. And
he was such a support right at the beginning. So I really appreciated when seniors help out, and I think it's really, it shows a lot of magnanimity to have someone who says that, look, why don't you go ahead. He encouraged us to register our center and train people in scanning. So I'm really passionate about obstetrician scanning. I really believe we should do it.
I think we all need to come to you for some time and spend some time in your clinic.
Thank you. Yes, ma'am.
Thank you so much,
Dr.
Anita
Anita
ma'am.
is a very good teacher, very good teacher. My daughter is a fan of her.
Oh, really?
She has been with you, madam, and she is just fascinated by you. She's a great admirer.
But she's scanning, I hope, herself.
Yeah. She has done fellowship in fetal medicine from
Excellent.
Chennai, but you are her role model.
Thank you, everybody, very much for that wonderful panel discussion. Thank you, Anita. Thank you, all the panelists. Dr.
Thank you, sir.
Datta, my good friend. Komal and Kundan, of course, I know them since so many years now. Dr. Sangeeta. I'm sorry that Dr. Kavita Bapat couldn't join us. I think that was a wonderful panel discussion, and it was quite succinct, it was comprehensive, and it was practical. And I think one of the indices which I always see when I'm in a webinar is whether the number of people at the end of the panel discussion are more or have reduced since the panel discussion began. And I'm happy to tell you that the number of people is actually more when your panel has ended compared to when it began. So that's obviously the best validation for this quite wonderful discussion. Thank you, everybody, very much. We look forward to seeing you all again next Wednesday for another interesting series. Datta, I'm sorry, you were saying something?
No, nothing. Carry on.
Yeah. So I'll leave it to Priyankur now to conclude. Priyankur, can you please take over? Thank you.
Thank you, Dr. Jaideep. Thank you.
Thank you, madam. Thank you.
Thank you so much, Anita ma'am, and thank you all the panelists. You really stuck to the task, and it was a wonderful panel discussion that we had today. We have a couple of questions that we'll take, but before that, we'll take a couple of questions for Dr. Krishnendu Gupta. So, sir, there's a question for you from Dr. Yashodhara. She asks, what type of Indian nutrition would you recommend to lactating mothers?
It had to be Yashodhara to ask me such a question. Anyway, thanks, Yashodhara. Well, I mean, I don't want to sound theoretical, but there are various types. I mean, basically, it's vegetarianism in India that is a problem. And I had said that the things which are really deficient are iron, calcium, zinc, vitamin B12. And as you know, don't want to sound theoretical, but there are various types of vegetarians. Like there's ovo-lacto-vegetarians, which includes dairy and egg products. There's an ovo-vegetarian, which includes eggs. There's lacto-vegetarian, which kind of include only dairy products. And of course, vegans, which exclude eggs, dairy, and other animal products. So in such women, we have to kind of alternate the protein sources, which can come from tofu, as I had mentioned when I had spoken. It could be beans, peas, nuts, and stuff like that. So in people who are not very wary of having milk products, you can add milk. Those who don't want to have milk, then you have to supplement with other stuff. So basically, the issue is the vegetarianism, and the biggest problem is the animal source, where we don't have any vitamin B12 and stuff like that. So they have to be supplemented. I hope I've answered Yashodhara.
Thank you so much. There are a couple of questions for Jaideep sir. The first one is from Dr. Rekha in Agra. She asks, TD followed by TDAP after 6 weeks. Is this to be followed?
As long as you have an interval of 4 weeks, it's perfectly fine. 6 weeks is not really required. And you could either give TDAP first or TD, but you'll have to refer to that slide which I showed you earlier of when to give the vaccine.
Right.
Probably a good idea to give TD followed by the influenza virus vaccine followed by TDAP later on in the trimester. That's what we are following now.
Thank you, sir. There's another question. Would you recommend COVID vaccine for your patients? And if yes, when? Means which trimester in pregnancy?
So as I already said, we can hardly expect the same kind of data for COVID, and particularly the COVID vaccines that we expect for the other kind of diseases, and what I like to call stringency of evidence that we use for COVID has to be a little more elastic than what we use for other diseases. There are two very contrary opinions. One is from the American College, which suggests that you counsel the women, inform them about the lack of data about COVID vaccine and pregnancy, and then let them decide. And there is the other stream of thought from the Royal College, not from the Royal College, it's from the UK government actually. The Royal College has just given a comment on it, and the UK government feels that unless the woman is at risk for COVID, it's a good idea not to let her take the COVID vaccine. So I think the short answer is we need to wait for much more data. But if you were to ask me what I would do, I would say that I would counsel the patient, and I don't like to make recommendations, or I don't like to be judgmental about all this, but in the current state of affairs, unless the patient is at risk for COVID, I would like to hold on with the COVID vaccination for now. And there are a couple of reasons for this. One reason simply being, as I already talked about, is the lack of data. And the second is that the kind of technology that is being used in the vaccines under use has relatively new and unexplored. And, one has to be a little skeptical and cynical about that also. So as of now, the short answer is, if someone were to ask me, unless the pregnant woman is at risk for COVID, I would avoid a COVID vaccination for someone who's pregnant. At the same time, if somebody has taken the vaccine and is conceived quite immediately after taking the vaccine, or has taken the vaccine in pregnancy, I would certainly not recommend an MTP. I mean, that's equally important to say, as much as not, recommending the vaccine.
Yes, sir. And one more question for you, sir, from Dr. Sumanta Mondol from Kolkata. what should be the gap between pregnancy and MMR vaccine administration?
Well, in the earlier days, we used to think that 3 months is required, but now I believe anywhere from 4 to 6 weeks is quite sufficient. Personally speaking, with the medical legal climate, etc., I would prefer 6 to 8 weeks, and write it on paper when you give the vaccine that you're not supposed to conceive for at least the minimum of 6 to 8 weeks.
I totally agree with you, Jaideep. It's very important.
Thank you.
Thank you, sir. There's one question for Anita ma'am, and this is from Dr. Maninder Ahuja from Faridabad. She asks, should hospitals take some responsibility for this rare cases? She means to say those rare anomalies, etc., where reduction, etc., needs to be done if parents cannot take up the expenses.
Well, we are very fortunate in Delhi that we have public hospitals also. We've got AIIMS. So they also do a lot of cases. So there's never a problem in Delhi, at least. So Maninder, whom I know, so the ones who can afford it, they come to us, and the ones who can't, they go to AIIMS, essentially. But I can't say that we are so fixed on money that, we wouldn't offer them anything. So like laser fibers, it should be a single laser fiber which you throw away. So often we use it again. The RFA, as Dr. Datta mentioned, it's expensive. It's like 80,000 for a single use. So that is reused. But bipolar is cheap. It's lying around in your OT. We have fetal ones, so they're much smaller and they're much thinner. But solutions can be found, essentially.
Thank you so much, ma'am. Thank all who have participated in today's webinar. And I would like to welcome all of you to the webinar on the 13th that will be moderated by my good friend Rohan. And that day we have the topics of recent advances in management of PPH, oral and parenteral nutrition supplements in labor. And we have an excellent panel discussion which will be on blood and blood products used in pregnancy and labor, which I think is very, very important. So I request all of you to log in for the next week's session. And sir, before I end, Jaideep sir, I would like to read out a comment from Dr. Lakshmi Shikhande ma'am. She says, I am privileged to see the journey of Dr. CN sir from Secretary General of FOXI to FIGO President. Now I am eagerly waiting to see the same journey for you, especially with the first stepping stone being next year as the FOXI President. So this is a comment from Lakshmi ma'am, and I would like to mention this over here. And all the best to you, sir. Thank you so much, everyone. Now I would like to hand over to Team Torrent, Mr. Somnath, for the vote of thanks, and after that we end the session. Thank you all.
Thank you very much, sir. On the behalf of the entire team of Torrent, I must thank our eminent speaker, Dr. Jaideep Tank and Dr. Krishnendu Gupta. Our chief guests were Dr. C.N. Purandare and Dr. Nozier Serier. Moderator, Dr. Anita Kaul and Dr. Priyanku Roy. Series convener, Dr. Parikshit Tank. Panelists, Dr. Datta Panilkar, Dr. Sujata Kar, Dr. Kavita Bapat, Dr. Rahul Tyagi, Dr. Kunda Ningale, Dr. Komal Chavan and Dr. Sangeeta Rai, who has given us time from their busy schedules. This program would have been incomplete without your experience and knowledge. And my special thanks to all the audience for making this video conference successful. Thank you so much.